Okay, so hello everyone, and thank you, Rupert and Sarah, for the opportunity to present at this exciting conference. First, my disclosure related to patents for the use of ketamine and the treatment of PTSD. None have yet been licensed. So, following the findings on the effectiveness and efficacy of ketamine for TRD, treatment-resistant depression, we embarked at Mount Sinai on studying whether ketamine might help patients with chronic PTSD. And this is because there is a lack, insufficient therapies, both medication treatments that are sufficiently efficacious for PTSD, and also trauma-focused psychotherapies. Although they have the most empirical support, they have pretty high rates of non-response or partial response or treatment dropout. So following we started over a decade ago with the first RCT of single ketamine infusion crossover with midazolam at Mount Sinai, and we had some encouraging positive results. And so we then embarked on this randomized controlled trial of repeated dose intravenous ketamine for PTSD. And as Rupert mentioned, I presented the findings recently at the Ketamine Journal Club. And so I'm going to go over these findings briefly to summarize them, and they are published now. They were published in February. So this was a study where patients with chronic PTSD were randomized either to receive 6 infusions of ketamine, the usual dose of 0.5, 3 times a week over 2 consecutive weeks. So typically, not always, Monday, Wednesday, Friday, Monday, Wednesday, Friday. And the primary outcome was at the 2-week time point, usually the following Monday. And it was a double-blind, randomized clinical trial, and the other half were randomized to midazolam as psychoactive placebo control. Briefly, these were the inclusion criteria: men, women. They had to meet DSM-5 criteria for PTSD, and significant severity of PTSD symptoms. They had to have a CAPS-5 score of at least a 30, which is several points into the moderate range, moderate to severe. And then a couple of exclusions. So we excluded individuals with serious unstable medical illnesses, but if they had, for example, well-controlled high blood pressure, hypertension, diabetes, those were not exclusionary. We also excluded individuals who had comorbid bipolar disorder or chronic psychotic disorders such as schizophrenia. Past history of drug or alcohol use disorder was fine as long as they didn't meet criteria for the previous 3 months, and they didn't have a history of recreational use of ketamine or PCP. And a range of concomitant psychotropic medications were allowed. We did not allow concomitant opioid medication, and also participants on long-acting benzodiazepines, like clonazepam, for example, were excluded. But if participants were taking short-acting, even in the daytime, prazolam, lorazepam, benzodiazepines, we would hold the dose. We would ask them to not take their morning dose during the one just prior to the infusion. So this is a consort diagram. And so as you see, 15 were randomized to ketamine and 15 to midazolam. So this is it was a pretty small study, and originally planned to go to 40, but we did interim analysis that were partially unblinded conducted by an independent statistician, drug A, drug B. And because there was a significant separation, we, in consultation with the DSMB for the study, we decided to end the study with 30. So briefly, as you can see, the mean age was about 39 years, and it was about the 3/4 female, the sample, and a range of ethnicities, and they all had on average, very chronic PTSD of about 15 years. And the CAPS at screening, CAPS-5 score over the past month was around 40 to 41. So that's pretty severe. So some, there was a range. And MADRS score for depression. You can see there comorbid, the rates of current diagnosis of comorbid MDD on the SCID was about 2/3 or 3/4, 2/3 to 3/4, and a range of traumas. Primarily, the most common one was sexual assault or molestation, followed at the bottom where it says primary trauma. You can see the range of traumas. This is a summary of the findings from the study. So you can see on the left that there's a clear separation from 0 to 2 weeks, the primary outcome. So the improvement on ketamine, the red line, was robust and rapid. In fact, we found that we did a 24-hour, so those who would go on to improve significantly on ketamine were already better at 24 hours. And compared to the flatter tracing for midazolam. And really the improvement did not differ across the 4 symptom clusters of PTSD per DSM-5, with the exception of, so they were all significantly different except at a trend level. The difference was a trend level in the arousal reactivity subscale or symptom cluster. And we thought maybe this is due to midazolam helping some with perhaps sleep or other arousal and reactivity symptoms. It's a hard comparator, as you know, to go against because it is an anxiolytic. So it could have temporarily improved some of these symptoms. And if we define the response as based on several other studies having defined use this criterion for response, and basically in the ketamine group, 2/3 or 67% were considered treatment responders compared to only 20 in the midazolam group. And these are some selected quotes, which are also included in our published paper in the online supplement. And you can see these are ketamine individuals who responded very well to ketamine. I don't feel my life is going to end anymore. Before it made it impossible to plan a future. Another patient said, I feel like a normal person. And it doesn't, the thought, she's no longer thinking about suicide all the time. And she has to dig out the memory of her trauma as if from an attic. Before, she used to have a terrible feeling when these memories would pop up. And then another participant said, I feel like I have energy and want to do things again. And I feel like I have made peace with the trauma. I could go past it, and a feeling of gradual acceptance. So we obtain these quotes over time. Sometimes, we were asking, and some of these are from the second week after the first week of infusion. Some of them are after the primary outcome, but sometimes we would even see that some of these beginning to emerge even the first day, a couple of hours after the infusion. And there was also improvement in comorbid depressive symptoms, also rapid, as assessed with the MADRS. And this is what we see. So the 0 time point here is the 2-week primary outcome. So the median, so the majority, these are the 3 who had a response or placebo or psychoactive placebo response to midazolam. And of the 10 of the 15 individuals who got ketamine who were considered responders, most of them relapsed. The median time to relapse was a whole month or 4 weeks after the primary outcome. So 6 weeks after the first infusion, when most of them were already feeling somewhat better. And so what this shows is it seems that ketamine for PTSD repeated a course of 6 infusions seems to prolong maintain the improvement over a few weeks. So I wanted to focus a bit more today on our MRI findings, and wanted to mention Dr. Agnes Norbury, who's a postdoctoral fellow working with me and my research team, and she led and conducted these analyses. So you can see here that 2/3 or 20 participants of the 30 were able to complete 2 scans, one before any infusion started, And then the post-infusion scans happened usually after the 4th infusion, but sometimes after the 6th infusion, depending on scheduling. And it didn't happen the day of infusion. It was at least 24 hours after the infusion. And you can see also in this subset, we see a robust difference. And the pink is the pre-infusions, and the post-infusion scan is the blue. So you see a robust improvement in ketamine, but not so in midazolam. And what there were 2 tasks that were administered in both scans, and resting state connectivity. One is the Hariri et al. Very well-known task that elicits robust amygdala activation. And then this one is a task developed by Lisa Shin, and it's face stroop. And basically, there's a congruent condition where the word and the face have the same. They're both, fearful face and the word fear. And this one is the incongruent condition where it says happy, but the face is fearful, and they're supposed to press the button that indicates fearful without being distracted by the word happy. And then here's participant is asked to look at the fixation cross during their eyes open and not do much of anything. There's no task. And there were a bunch of other measures that Dr. Norbury included in the model, clinical covariates, socio-demographic predictors. There were about 50% of those who were scanned were taking at least one concomitant psychotropic medication at stable doses. So I wanted to mention that this was allowed, and some patients were taking several medications, some of them just one psychotropic medication. And then we also included in the model other, the CADS, dissociative symptom, psychotomimetic, manic, one question from the Weimars, and then any physical somatic side effects that patients experienced. The analytic approach that was used was based on pre-hypothesized regions of interest that have shown, that have been found to be abnormal and abnormal connectivity in studies of patients with PTSD. And they're summarized here: dorsal ACC, rostral, ventromedial PFC, anterior hippocampus, anterior insula, and amygdala, and the relationships with them, between them, connectivity. And because there were so many variables that were included, this regularized regression approach was used, elastic net, which actually deals well with multicollinearity. It's used when there's a small sample size and the number of measures, predictor or correlate measures here. And I want to say what we are predicting is improvement in PTSD symptoms as measured with the CAPS from pre to post, from pre to the primary outcome. So correlates and predictors of improvement in PTSD symptoms. So when there's more measures than the number of subjects, and then this method was used where you rotate and leave one subject out for cross-validation. So you train the model in the others, so there are 20 subjects, so in the 19 subjects, and leave the other one out and try to see if you can predict the findings in the one that was left out. And then you leave another one out and put that one back in. So it's as if you had 2 data sets, a training one and a confirmation one or validation. And because of the small sample size, we also pre-registered the data, all this plan online before doing any analyses. And so briefly, these were a summary on correlates of symptom improvement. And basically, there were 11 predictors or correlates. So the dependent variable is improvement from pre to post ketamine infusions, all 6. In the CAPS-5, or specifically PTSD symptom improvement. And you can see in green, there are 11 of the Hariri, 11 emotional faces tasking MRI. This one is connectivity between the ventral medial PFC and the amygdala. And then there's 8 from the Lisa Shin task were entered from the face stroop, and then 9 from the resting state connectivity variables. And then here you see the demographic characteristics. And so here is, regardless of drug agnostic, an increase, the most robust predictor of symptom improvement from pre to post treatment after the 6 infusions was an increase in functional connectivity between the ventral medial PFC and the amygdala during emotional phase viewing. And then looking specifically at the interaction with drugs. So here, all the interaction terms with all the MRI tasks, all these variables were included in addition to the other variables that were there before. So we see here, it still persists, and I'll show you, and there is an interaction, drug by emotional phases in the ventromedial PFC and amygdala. So here it is, there was an interaction between this increase in ventromedial PFC and amygdala connectivity that was stronger. It was still retained in the Willing model, suggesting that this association was stronger in individuals in the ketamine group compared to the midazolam group, which is flatter. So the greater improvement from pre to post infusions in PTSD symptom severity as measured with the CAPS was associated with greater change, improvement, increase in ventromedial PFC amygdala connectivity. And interestingly, when Dr. Norbury looked at, this is a 7 symptom dimension model of PTSD that goes beyond DSM-5. And what we found is that there were stronger relationships between this improvement in connectivity of the VMPFC and amygdala and the prototypical PTSD symptoms, such as re-experiencing, so the R squared, close to 0.3, close to 0.3, close to 0.3. The other symptoms are smaller, and here there's no correlation, for example, with negative affect, small with anhedonia. So it's these three that are most robustly related to this change. So this one is re-experiencing, avoidance, and anxious arousal. This 7-dimension model separates anxious arousal from dysphoric arousal, and anxious arousal is basically hypervigilance, and the other symptom is increased startle. Further, in addition, this was only observed in the ketamine group and not in the midazolam group. We saw a decrease in abnormal activation of dorsal anterior cingulate activity when this is the contrast of incongruent condition in the face droop task with the congruent condition. So typically in studies of PTSD, we see hyperactivity of the dorsal ACC. And here we saw that with greater improvement on pre-post in PTSD symptoms, there was a decrease in this, what we think is overactivation of the dorsal ACC. And then in the resting state connectivity, there was the higher the improvement from pre-post infusions in PTSD symptom severity, the higher or greater the improvement in ventromedial PFC and anterior insula during resting state. So the results of these, actually, I won't have time to discuss the details of this dynamic causal modeling, but Dr. Norbury further looked at directionality of, was it the amygdala or was it the ventromedial PFC, the main finding? And she found with this DCM approach that really the ketamine group showed greater top-down inhibition of the amygdala by the ventromedial PFC. There was a separate lessening of the amygdala to ventromedial, so down to top, ventromedial PFC excitation that seemed to be regardless of group, midazolam or ketamine. But greater top-down inhibition was specific to the ketamine group, and this has intriguing parallels to the neural mechanisms implicated in successful extinction learning as conducted by Dr. Daniela Schiller and others, where there might be the same regions and higher activation of the ventromedial PFC is associated with more success in extinction learning. And this is my last slide. So as we've been talking about, ketamine is thought to open, and Dr. Sanakora mentioned, is thought to open a window of increased neuroplasticity. And so a lot of people are very interested also specifically in PTSD, but obviously depression. Dr. Sam Wilkinson would talk about that tomorrow. And recently we heard about this in substance use treatment, adding a trauma-focused therapy to ketamine treatment for PTSD and its potential synergistic effect. And the idea being that there's some evidence from animal studies that ketamine enhances extinction learning. And then also this window of increased neuroplasticity. And we plan to test this idea at Mount Sinai by adding a brief exposure-based therapy to a course of ketamine infusions and to see if this combination can prolong maintenance of, so reduce the relapse of that loss of response over a longer period of time. And we're also going to add a task that was developed by Dr. Norbury, which is an online extinction learning task. And so we're going to see whether an improvement in extinction learning following the first few infusions is associated, can predict longer time to response, longer time before loss of response to ketamine. So I'd like to acknowledge, this was a large team, to acknowledge my mentor, Dennis Charney, with whom I began my studies of ketamine for PTSD, and Agnes Norbury, without whom these analyses would have not been possible, and then Dr. Sarah Costi as well, co-organizing this conference. She was a key contributor to the study when she was at Mount Sinai, and many others. Thank you.